If the initial recurrence was in the lung only, that was the best situation, and if the patient had symptoms at recurrence, their relative risk was more than twice, relative risk of dying was more than twice as high. The most common reason for giving no treatment was rapid progression of disease recurrence. The next most common reason was that patients refused treatment. And so what are we to conclude from this? Does the fact that patients with asymptomatic recurrences or other markers of early disease at the time of recurrence, was the fact that they did better true impact of surveillance in this group, or was this just lead time bias? Were we just identifying the disease earlier in its natural history and not really changing the natural history? And the answer is we don't have any data one way or the other. The issue of second primary tumors, because they have a better survival when we treat them, this is where a lot of groups have focused, metachronous or second primary lung cancers. This is data from Bruce Johnson. He did a massive review, published it in 1998, 11,000 patients, 416 second primary lung cancers, and the incidence varied from 1 to 4% per patient per year. Most of these numbers were in the 1 to 2% range, though, if you look at that side of the table. He then looked at median survival and the number of patients with second primary lung cancer who were resected. Of the 494 patients, 54% could be resected. Median survival was 1 to 2 years. So there could be meaningful survival when you detect second primary lung cancer. The best data perhaps comes from the chemoprevention trials. This is a trial reported on by David Rice from MD Anderson. This was the cisretinoic acid chemoprevention trial, phase 3 randomized study. They looked at, there was prospective data collection here looking at second primary lung cancers. And they looked at the placebo arm of the group. So even though cisretinoic acid did not actually prevent second primary cancers of any kind, they took the precaution of just looking at the 569 patients who had path stage 1 disease in the placebo arm. Median follow-up was 5.9 years. The surveillance program consisted of semi-annual follow-up with a chest x-ray. They used definitions. If patient had different histology, it was a second primary lung cancer. Similar histology in a different lobe or after, generally after 5 years was considered a second primary lung cancer, although a few patients had shorter intervals between their original surgery and the second primary lung cancer detection. They found that the cumulative incidence of second primary lung cancer increased over time. That they worked out to about 2 per 100 patient years, or 2% per patient per year in likelihood of developing a second primary cancer. And this is the number that we're all mostly familiar with. Despite semi-annual chest x-rays, I put quote unquote there, 12 presented with distant metastases at the time of diagnosis. And they point out in the paper that the median diameter of these tumors was only 2.7 centimeters to defend against the accusation that, well, if you had a CT scan, maybe you would have picked these things up earlier. They're saying that the tumors weren't very big, even though patients had 2 centimeter tumor with distant metastases. So they're defending the use of chest x-ray. 63% with second primary lung cancers underwent a reoperation. The median survival in the group that had surgery was 4 years. If you couldn't have surgery, survival was 1.4 years. Again, suggesting that surveillance might be useful, or again, is this just lead time bias? 2 additional patients were alive without disease. They were treated with radiation alone or chemoradiation, just to point out that surgery isn't perhaps the only curative modality in this setting. Another important finding is that while the first resection was a lobectomy or some other standard resection, they had a higher incidence of wedge resections and less than lobectomies in the patients with recurrences, suggesting that patients can not necessarily have a curative resection or a traditional curative resection because their lung function is decreased after the initial resection. And then smoking cessation, or the impact of continued smoking, was an important finding in this study. Patients who were current smokers at the time of their first operation had a higher incidence of second primary lung cancers. And this data from the Bruce Johnson review demonstrates that for patients with small cell lung cancer, continued smoking has been shown to increase the risk of developing recurrence. So the role of smoking was pointed out by the David Rice study. And this is just to show the difference in survival between recurrences and second primary lung cancers, and why most surveillance studies have focused on this group, the second primary lung cancer group, because there's a better survival and a better likelihood of a better utility of performing surveillance. I'd like to finish with this study from Dr. Altorki's group. Dr. Kent and Dr. Korst worked hard on this decision analysis. These are always interesting things to look at. They modeled outcomes of a hypothetical cohort of patients undergoing surveillance with a once-a-year CT scan after resection of stage 1A non-small cell lung cancer. And they took the data from the literature on the incidence of second primary lung cancers in this group, the stage distribution, the likelihood of curative intent treatment, and cost from lung cancer screening trials, hospital charges, Medicare reimbursement schedules. So the model is always important, but the source of the data for the model is always the second most important thing when you're evaluating these decision analysis studies. And this is how the tree here, decision tree, works out. Everyone had a surveillance CT scan. Patients were either dead of other causes, had no evidence of disease, had a second primary lung cancer detected, had a recurrence detected, in which case they assumed that they would die of their disease, or had an interval second primary lung cancer detected before the CT scan, which meant that it was symptomatic, and again, they assumed that if you had a symptomatic recurrence, you're going to die of your disease. And they assigned these patients 12-month survivals. A negative CT scan and false positive CT scans were included in the decision analysis here. They looked at quality-adjusted life years. So if you had a false positive CT scan, they subtracted some from your quality of life, and that works out as taking a few days or weeks off of your overall life expectancy for undergoing additional tests that you don't need, and so on. If you had a second primary lung cancer detected, they broke it down into these patients unresectable. For the reason unresectable primary lung cancer, they had pulmonary insufficiency. A better rationale for performing surveillance in these patients. Higher up on the effort list, we could consider mounting a registry trial looking at lung cancer survivorship. We talked about this somewhat yesterday, and registry trials are not very popular, certainly not with CTEP, but perhaps with the Division of Cancer Prevention, they might be interested in looking at something like this. What we really would need to do is look at a randomized trial, and perhaps we could sell this as a health technology assessment trial looking at cost effectiveness. The government is sensitive to the accusation that they're rationing health care, so I don't know if politically this would be very appealing either. We perhaps should just wait until we have some fundamentally different technology to use in a trial. Quality of life components are more important these days, or considered more important. They could be included in any study. There was an article in the papers I was flying down from Philadelphia about patients undergoing scan-anxiety, and some poor patient was getting a scan every month for whatever cancer they were treating her for. I'm not sure why they were doing that, but she lives from month to month on the basis of what her test results are. And then we can incorporate tissue collection, which would be useful in helping to predict or look for markers of recurrence. More practical suggestions include smoking cessation in some of our trials, and certainly in our clinic work. We talked yesterday about capturing data on recurrence and treatment in the STS thoracic database rather than just stopping at 30-day results. Perhaps we could consider endorsing one standard for CT surveillance for all clinical trials so that we could then look at the data afterwards and pool the data, much as the lung cancer study group did with their trial that I mentioned. Consent and HIPAA issues are important here. There is an ongoing chemoprevention trial with selenium that you're aware of, and we're awaiting the data for that. And then we need to await the data for the national lung screening trial. I just put this table up here from Bruce Johnson's paper because he listed, as he went back and did his review, a number of important items that one should include in a database when it comes to recurrence. So a lot of that legwork has already been done. And again, I'd like to thank you for your attention.